All right, class, listen up. If there's one topic that's going to show up on your exams again and again, it's this one. Today, we're going deep into insulin, the body's ultimate boss, its master hormone. Let's do this.
So, just imagine, you just polished off a delicious plate of biryani. All that rice, all those carbs, they're breaking down into glucose, right? And suddenly, your blood is flooded with sugar. What happens next? How does your body manage this sugar rush? Well, the entire show, the whole metabolic drama that unfolds, is directed by just one molecule. And that molecule, my friends, is insulin. It really is the master key to everything.
So what is insulin's main job? At the end of the day, it's a gatekeeper. That's the best way to think about it. Its whole purpose is to get glucose, the body's main fuel, right, out of the bloodstream and push it into the cells where it's actually needed, for energy, for storage, whatever. It's a simple funda, isn't it?
Okay, so who is listening to this insulin? Who are its main targets? We're talking about three major players: your skeletal muscle, your fat, that's adipose tissue, and the liver. These guys are the main audience. But, and this is a very important point for your exams, look at that note. Your brain, your red blood cells, your white blood cells, they don't care about insulin for glucose uptake. For them, the door is always open. But for the big guns, the tissues that use and store the most energy, they absolutely need insulin to unlock that door. Right, so we know insulin is the gatekeeper. We've got that. But how? How does it actually turn the key in the lock? Now we have to zoom in right down to the molecular level. This is where the magic happens, what we call the molecular handshake. It's how insulin actually talks to a cell.
Whoa, okay, I know what you're thinking. This diagram looks complicated, right? Don't panic. This is the whole picture, the A to Z of what happens. But we are not going to swallow it all in one go. We're going to break it down, step by step, until it makes perfect sense. I promise. See? We can take that scary diagram and boil it down to just 4 simple steps. Think of it like a story. Step 1. Insulin arrives and binds. Step 2. The receptor gets activated. Step 3. A chain reaction of signals starts inside the cell. And Step 4. The glucose gates finally open. Binding, activation, signaling, action. That's it. Now let's go through them one by one.
All right, step 1 and 2 together. The insulin receptor is made of a few parts. Imagine 2 arms sticking outside the cell. Those are the alpha subunits. And then 2 legs that go through the membrane into the cell, the beta subunits. Insulin comes along and binds to the alpha arms outside. It's literally the key fitting into the lock. And what happens when you turn a key? It activates the mechanism inside. Here, the beta legs get switched on. And their special power? It's something called tyrosine kinase activity. A kinase is just an enzyme that sticks a phosphate group onto something else, like a little power-up. So the key is in, it's turned, and the first switch inside has been flipped.
Now for step 3, the signal cascade. Once that first switch is flipped, it's like a line of dominoes falling over inside the cell. That tyrosine kinase starts phosphorylating, adding those phosphate power-ups to the next guy in line, a protein called IRS. Then IRS activates the next one, PI3 kinase, and so on and so on. It's a chain reaction. And why does the cell do this? It's all about amplification. Think about it. Just one tiny insulin molecule outside creates this massive amplified signal inside. It's super efficient.
So what's the whole point of this internal relay race? What's the final message? Well, at the end of this cascade, the signal reaches these little storage bubbles inside the cell. We call them vesicles. And inside these vesicles is the real treasure. Little proteins called GLUT4 transporters. They are the actual glucose gates. The signal tells these vesicles to move to the surface of the cell, merge with the membrane, and bam! The GLUT4 gates are now open for business, and glucose can finally rush in. Mission accomplished. Okay, so we've seen the nuts and bolts, the how of insulin. Now, let's zoom back out. Let's look at the big picture. What is insulin's overall strategy for the body? What's its master plan? A great way to think of it is that insulin is the body's chief financial officer, or an economist. When the money, the glucose, is flowing in after a meal, insulin is the one who decides what to do with it.
Insulin basically wears 2 hats. On one hand, it's a builder. It's anabolic. This means it tells your body, hey, we have plenty of fuel. Let's build stuff. So it promotes storing glucose as glycogen, making new proteins, and storing fat. It's all about saving for a rainy day. But at the same time, it's a protector. It's anti-catabolic. It tells the body, stop breaking things down, we don't need to.
So it puts the brakes on breaking down glycogen. It stops the liver from making new glucose from scratch, and it prevents fat from being broken down. So it builds and prevents breakdown. Simple. And this is where all this theory becomes real life. This is why you're learning all this biochemistry. It's not just for exams. Understanding this is the absolute foundation for how we treat patients with diabetes in the clinic. So let's shift gears from the textbook to the bedside.
So when we treat a patient, we don't just have one insulin. We have a whole toolbox of different types of insulin. As you can see from this table, they are all designed differently. Some are like race cars. They act super fast for just a few hours, perfect to cover a meal. Others are like marathon runners. They work slowly and steadily over a whole day. This gives us a baseline level of insulin. The key is knowing which tool to use and when.
So how do we combine these different insulins? Look at these two graphs. The one on top is an older way of doing things, the split mix regimen. It's okay. But now look at the bottom one, the basal bolus regimen. See that flat blue line? That's the long-acting marathon runner insulin. And see those sharp peaks right at mealtimes? That's the rapid-acting race car insulin. Doesn't that look much more like what a healthy pancreas would do naturally? This is what we aim for, to mimic physiology as closely as possible.
But listen, insulin is a powerful, powerful hormone. It's a double-edged sword. And that means it's not without risks. Managing insulin therapy is a constant balancing act. Too little insulin is obviously a huge problem, but giving too much can be even more dangerous and much more acute.
And what's the number one risk we worry about? It's this: hypoglycemia, dangerously low blood sugar. This is something you and your patients must know inside out. The symptoms usually come in two stages. First, the body panics. The sympathetic system kicks in, and you get those classic warning signs: sweating, heart pounding, shakiness, anxiety. That's the body's alarm bell. If you ignore it and the sugar keeps dropping, then the brain starts to suffer. That's when you get neuroglycopenic symptoms: confusion, dizziness, headache. This is a true medical emergency.
Now, what about the other side of the coin? What happens when there's absolutely no insulin? You get this, a life-threatening condition called diabetic ketoacidosis, or DKA. Just follow the chain reaction here. No insulin means glucose is stuck in the blood, so you get massive hyperglycemia. The kidneys try to flush out this sugar, but water follows it, leading to massive dehydration. Meanwhile, the cells are starving. They scream for fuel, so the body starts burning fat like crazy. The problem is, this rapid fat breakdown produces these acidic things called ketones. The blood becomes acidic. So now you have a patient who is severely dehydrated and has acidic blood. This is a recipe for disaster, leading to shock, coma, and if not treated, death.
So there you have it. From a tiny handshake on a cell membrane, all the way to complex, life-saving treatments in the ICU, insulin is just incredible. For 100 years, it has been a miracle drug, changing diabetes from a death sentence to a chronic condition. But the story is far from over, and the real question I want to leave you with is for your generation, for you guys. We've had a century of insulin. What's next? What will the next 100 years of diabetes care look like? That's the challenge for you to solve. Hello everyone, and welcome back to our pharmacology class. Today, we're diving into a really important topic, Chapter 19, Part 2, Oral Anti-Diabetic Drugs. You see, we're going to figure out how we can manage type 2 diabetes, which is a massive problem, with just a simple pill, without needing any injections. So, let's get started, shall we?
All right, let's be honest. The biggest problem with insulin therapy, the reason so many patients just don't stick with it, is the needle. An injection every single day, sometimes even more, it's a huge burden, a real hassle. So, for years, the dream has been a simple pill. The question is, how do these tablets actually work to bring down blood sugar? And that, my friends, is what we're going to understand today.
So, here is our syllabus for today, our game plan. First, we'll lay out the overall battle plan. Then, we'll look at each strategy one by one. How to boost insulin, how to fight that stubborn insulin resistance, and how to slow down sugar from getting in. And finally, we'll put it all together to see how a doctor decides which drug to use when.
Right then, before we jump into specific drug names, let's look at the big picture. Think of this as our strategic map, our guide to controlling a patient's blood glucose. You know, what's great about this slide is how it simplifies everything. See, every single oral anti-diabetic drug we have fits into one of these three boxes. Either we make the pancreas pump out more insulin, or we make the body cells actually listen to the insulin that's already there,
Or we just slow down how fast sugar gets into the blood from our food. Simple, right? That's all there is to it.
So let's start with strategy number 1, the secret to GOGs. I know it's a fancy name, but it just means drugs that secrete or push more insulin out of the pancreas. These are the ones that give the pancreas a good, strong push.
Okay, look closely at this diagram of the pancreatic beta cell. See that channel on the left, the KATP channel? Well, drugs called sulfonylureas, or SUs, come and block this channel. It's like slamming a gate shut. This action traps potassium inside the cell, which causes a change in charge, and that forces all these little packets of insulin to be released. You can literally think of it as squeezing the pancreas to get every last drop of insulin out.
So the key takeaway here is that SUs are very powerful, no doubt about it. But, and this is a favorite exam question, Beta, their biggest, most dangerous side effect is hypoglycemia. Why? Because they force insulin release no matter what the blood sugar level is, so they can push it too low. Also remember, they cause a bit of weight gain, and they are useless if the patient's pancreas is already worn out. You need at least 30% of the beta cells to be working for them to have any effect.
Now, meglitinides are like the cousins of SUs. They block the very same KATP channel, but their action is super fast and super short. Think of SUs as marathon runners and meglitinides as sprinters. You give them right before a meal, they act quickly to control that post-meal sugar spike, and then they're gone. This makes them a bit safer when it comes to long-lasting hypoglycemia.
Let's go back to that same beta cell diagram. Now, I want you to look to the right side. See that other receptor, the incretin receptor? So after you eat, your gut releases these amazing hormones called incretins, like GLP-1. They send a signal to the pancreas saying, hey, food is here, release some insulin. But there's an enzyme called DPP-4 that destroys these incretins very quickly. So what do DPP-4 inhibitors like sitagliptin do? Well, they block that destructive enzyme, which protects our natural incretins and lets them do their job for much longer. Very clever.
And this is the most brilliant part. This is the key difference. Unlike the SUs, which are always on, just forcing insulin out, the DPP-4 inhibitors are glucose-dependent. They only boost insulin release when your blood sugar is actually high, like after a meal. This makes them much, much safer. The risk of hypoglycemia is very low. They truly work smarter, not harder.
Okay, Cello, let's move to our second major strategy. With these drugs, we are not trying to force the pancreas to work harder. No. Instead, we are making the body more sensitive to the insulin that is already floating around. We are trying to tackle the root cause of type 2 diabetes, which is, of course, insulin resistance.
And when you talk about fighting insulin resistance, there is one and only one undisputed champion, metformin. This is the first drug that almost every single patient with type 2 diabetes will be started on, unless there's a very good reason not to. It is the absolute cornerstone of therapy.
So why is it the champion? I mean, just look at this list of benefits. First, and most importantly, it does not cause hypoglycemia. Its main job is to tell the liver to stop producing so much extra glucose. It also helps the muscles use insulin better. It can even cause a little bit of weight loss. And critically, it doesn't burn out the pancreas. And the final proof? The huge UK PDS trial showed that it reduces long-term complications, which is the whole point of treating diabetes in the first place.
All right, now for a slightly more complicated mechanism. Deep inside our fat and muscle cells, there is a special receptor called PPR-gamma. Now, don't get scared by the long name. Just think of it as a master switch that controls a whole bunch of genes related to how our body handles sugar and fat. This master switch is the target for our next class of drug.
So a drug like pioglitazone, which belongs to a class called thiazolidinediones, goes in and directly activates this PPAR-gamma switch, and by flicking this switch on, it fundamentally rewires the cell's genetics to make it more sensitive to insulin. So it's a true insulin sensitizer working right down at the level of our DNA.
Okay, on to our third and final strategy. And this one is actually very easy to understand. The logic is simple. If we're having trouble managing the sugar once it's inside the body, why not just slow down how quickly it gets in from our food in the first place? This whole class of drugs works right there in the intestine.
Imagine a massive traffic jam on the highway. That's basically what drugs like acarbose do inside the gut. They block an enzyme called alpha-glucosidase, which we need to break down complex carbs, like starch, into simple sugars. So the whole process of digestion slows right down. The sugar gets absorbed much more gradually, and you don't get those sharp, dangerous spikes after a meal. But
there's a big catch. What happens to the carbohydrates that you don't absorb? Well, they stay in the gut, and the bacteria there have a party. They start fermenting it. And this leads to the biggest clinical problem with these drugs: gas, bloating, and diarrhea. Because of these really uncomfortable GI symptoms, many patients just can't tolerate them for very long.
So now we've seen 3 completely different strategies to lower blood sugar. So how do we actually use them in a real patient? Let's put all this information together into a practical approach that you will actually use when you're in the wards.
This is the standard step-by-step approach you will see everywhere. Step 1. The moment a patient is diagnosed, they start with lifestyle changes and metformin, always. Step 2. If that's not enough to get their HbA1c to the target, we add a second drug. Usually this is a sulfonylurea, because they are very effective and quite cheap. And step 3. If we're still not winning, we can add a third oral drug like pioglitazone, or at this point, it's often time to think about starting the patient on insulin.
Now, why are we so aggressive about this? The proof comes from the UK PDS, the UK Prospective Diabetes Study. It's impossible to overstate how important this trial was. It was the first massive study that proved, without a doubt, that getting tight control of blood sugar using drugs like SUs or insulin prevents the horrible microvascular complications of diabetes, damage to the eyes, the kidneys, and the nerves.
And this study, they followed these patients for more than 10 years. This long duration was absolutely crucial because it showed something amazing and unique about metformin. While good sugar control from any drug helped with the small blood vessels, the group on metformin was the only one that also showed a major reduction in macrovascular events like heart attacks and strokes. This is the killer evidence that makes metformin the first-line champion.
Okay, time for a rapid-fire revision. These are the fundas for your exams, so listen carefully. Metformin is first line for everyone, period, unless there's a contraindication. Sulfonylureas are powerful, but always watch out for hypos. DPP-4 inhibitors are the smarter, safer option for boosting insulin. And pioglitazone is your main weapon against insulin resistance, but be careful about its side effects like fluid retention and edema.
And finally, just a thought for the future. We've talked about the classic drugs today, but this field is changing so fast. We now have newer classes like SGLT2 inhibitors, which work in a totally different way by making the kidneys pee out excess sugar. So this raises an interesting question. Is the future of diabetes treatment not adding pills one by one, but maybe starting with smart combination pills that hit multiple problems at the same time, right from the very beginning? Something for you to think about. Thank you for your attention.